Thank you so much for that nice introduction. And Detlef, thank you for having me here. I tried to come last year when the U.S. government was closed down. I tried to come yesterday when Lufthansa was closed down, so I'm really delighted to be here. While I was on the train yesterday from Frankfurt, I was really thinking about this presentation and the meetings I've been involved with in Washington around Ebola, and appreciating that some of the problems, we see Ebola as a problem of national security in the United States and a problem of global security. HIV 25 years ago was exactly the same. We had minimal cures and understanding of how to prevent and treat, and it was really a death sentence in much of the world. And that parallel, to me, has interesting common features today that come to my ultimate message, which is that investments, long-term investments in people and in institutions and in young researchers can really yield major differences, innovations that have changed the way we think. And I'd like to talk about that and give a few examples. NIH, as you know, is the largest funder of research in the world. We have as our mission pursuit of fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to extend healthy life. Our director, Francis Collins, when he became director, put on his agenda global health, expanding research in diseases affecting the developing world as one of his top priorities, and I'm happy to work with him on this agenda. Now, I direct the Fogarty Center, which is specifically focused on global health, but we work with all the other institutes at NIH to address global health, and this has changed. It's changed because a decade ago, global health was infectious diseases and HIV, and today global health includes all the non-communicable diseases, and he's commissioned all of the institute directors to do something in their agenda on global health, be it in cancer, as Ron was mentioning, cardiovascular disease, which is the #1 killer in the world today, mental health, and the like. There's a huge mandate and interest in global health on campus. At Fogarty, our interest has been in developing the next generation of young researchers, both Americans and foreign. And it's interesting that 10 years ago, most of the people we trained, and this is a group of about 90 people we sent out in July to work on research, mentored research in global health. 10 years ago, these were all working in HIV and infectious diseases. Today, these are young people working in cancer, heart disease, diabetes, and the like. And why the difference? Because in the U.S. today, we have loads of researchers with international experience in HIV and infectious diseases. We have precious few who have thought about the issues of the non-communicable diseases and the implications for the developing world. And this partnership is something that we really see as building over the next decades. Our first foray into support for global health research came 25 years ago with our AIDS International Training and Research Program. This was a time, if you recall, that AIDS in the U.S. was a problem of the 3 H's: Haitians, hemophilias, and homosexuals. And it was a death sentence at the time. Over this past 25 years, through Fogarty programs, we've supported partnerships between U.S. and foreign institutions to work together for training and research. And in that time, these are the long-term investments. They're relatively inexpensive because we're counting on people to grow up in their careers as researchers. But the consequences of these small investments in people and in institutions have been absolutely astronomical. In our training program, people that we trained 25 years ago, and like Glenda Gray and Slim Karim in South Africa, have become leaders in the HIV research community, have become heads of the medical research councils in their countries, and have really become independent investigators, defining how we can get out of the AIDS epidemic, how we can treat patients and prevent disease. It's really made changing AIDS from a death sentence to a chronic disease, just like we'd like to see for cancer. So it provides us a model of how we go ahead. And if you think of the innovations such as male circumcision or the single response at the time of pregnancy, PMTCT, these breakthroughs have all been made, and many of them have been made by trainees who have come through this AITRP program, learned, partnered with U.S. institutions, and made a difference. And they represents the fact that discovery is on the front line, and the frontiers of science really are in the areas where these are the key problems. These groups have stayed in country. They've funded themselves, they've supported their institutions, and as we've moved on to new programs, they've become leaders of their own institutions at home. So, as we finished the first PEPFAR program, PEPFAR could only be introduced by President Bush because of the innovations that were made from research done in Africa on HIV. Without those innovations, without the drugs, without the treatments, we would be nowhere today. And I think that's an important underline of this long-term investment in research. We're now in a position where we have now, after the first 5 years, 2 million people were on HIV drugs. Today it's about 8 million people, and AIDS is now seen as a chronic disease and not a death sentence. We still have a lot more to do, and we have to change the program from an American-based program to one that's sustainable in the long term. And to make it sustainable in the long term involves training and capacity building in the countries where this is a key problem, as well as a continuation of the research agenda. Now, the response from NIH and from PEPFAR and NIH has been to develop the Medical School Partnership Initiative. And last year at this meeting, we had 3 of the leaders of the MEPI program speak to you about what they're doing for global health. Nelson Suankamba was the head of the PI Council, and his issue is not only how to train doctors, biomedical scientists, and allied health personnel, but how to retain them in country, because the migration out of country was a key problem. Could research be used and building up institutions be used as a way to keep people in country, make them independent researchers, and be leaders in their own setting? And I think this is part of the message I want to deliver. Yes, we can. The MEPI program, as it's called, represented a $100 million investment from PEPFAR, about $30 million from NIH to support linked research to African sites. The ownership and the grantee was the African institution, not an American institution. The deans and rectors and vice chancellors had the opportunity to innovate, to build new curricula, to strengthen their ICT infrastructure, to introduce e-learning platforms, to work on faculty improvement and retention and training. So the desire to train and who they trained was in the hands of the African leaders and not from some group at NIH deciding on who should be trained and who shouldn't. And it's been incredibly successful. It's done a lot. It's introduced things like broadband on campus, long-distance learning, ITs. Tablet PCs will be in the hands of every graduate of the MEPI schools in Africa, and we see the access to global knowledge and a tablet PC or internet as important to physicians in the 21st century as the stethoscope was to us who trained 20 and 30 years ago. Access to knowledge. Also, when you think about HIV treatment, the treatment has changed every 5 years or less. And if you want to stay abreast, you can't be in a rural hospital not knowing. And if you want to introduce innovations like Ron suggested, if you have patients who should get better treatment, this is where they're going to get their information. So just opening up the broadband on all schools and introducing IT is absolutely a game-changing strategy. This is the library I visited at the University of Nairobi in the basement. It was a library set up when the institution was established 50 years ago. And these are the books from 1960s and 70s and journals that have been replaced by clean shelves and an internet capability as an information center. This is transformative change and is making a difference. We've also thought about improving the quality of healthcare workers, because as the number of medical students has ramped up in Africa through this program, the quality of education has to be ramped up as well. So things like skills laboratory, where not only can you work on mannequins, which has become standard procedure in the U.S., but you can train teams together of physicians, nurses, pharmacologists, public health people to think about procedures and development. This is another game-changing difference as we go forward. Faculty retention, a main problem of keeping personnel in Africa. You know, a quarter of our physicians in the United States are foreign trained, and so we are the main recipients of the largesse of other countries. This MEPI is a way to put back and reinstitutionalize what we're doing. And I think that research is one way to retain people, among other things, providing opportunities, putting internet access into district hospitals. So even if you're in a district hospital, you have access to the latest information. You can see consultation. You can join video conferences. We've also put through NIH a small grants program, and I think this is an idea that we're thinking through with Wellcome and Gates to provide, if you will, an NIH for Africa, an Africa-based small grants program that would provide major research funding in the continent. Sustainability is critical, and the sustainability means a lot of things. It means that we have, on each of the MEPI sites and major academic centers, a research support center so that research funding can come into institutions, and some of the hurdles of getting research through electronic entry systems, grant writing sessions, and the like can allow for sustainability of research on campuses. Building collaborations and partnerships. And on MEPI, it's been striking not only the North-South collaborations, but the South-South collaborations and the collaborations with public-private partnerships. So I have to talk to Ron after this session to line him up for his contributions to this endeavor. And finally, taking part in the global community, because getting our African scientists here last year, I think really stimulated them about how they could engage in Germany in their development of medical education and research, as well as with the Asian MEPI counterpart, and the Lancet Commission with Richard Horton and the group trying to improve medical education. So the networking has been absolutely incredible, and the PIs of the MEPI network, 13 schools, that when they came together did something that I never would have done in Boston. You know, in Boston, when I was an undergraduate medical student, any grant that we got came to our institution. But in the MEPI program, these deans, like Nelson Suankambo in Uganda, went out and brought all of the medical schools in the country into the MEPI network. In Zambia, this has led from one school being involved to 4 schools, 2 private, 2 public, and a new medical school growing up, so that the MEPI program is feeding trainers and instructors, researchers to all the schools. They've networked amongst themselves. They've networked between Southern collaborators and donor partners. It's been an amazing partnership that's going to continue. So I think this move of MEPI has been a game changer. We're looking forward to continuing this in some level in the renewal, and it really has strengthened the workforce. And it's been on the back of AIDS money and PEPFAR money. But we should be able to do more, especially because in Africa and many other sites, but particularly in Africa, AIDS is an incredibly important disease, but it's clearly not the only disease. So as we look forward, the NCD agenda is upon us, and as we talk to African leaders, and as life expectancy throughout the world has gotten older, it's the chronic diseases, the diseases of the future that we have to address, as well as the organization of health services. Well, some of our linked awards then are based on the MEPI platform, are based around HIV, but are in other areas, like here in Zimbabwe, improving mental health education, or treatment of cerebral vascular disease, heart failure, rheumatic heart disease, problems there. In Malawi, it's treatment of malignancies and getting pathology and telepathology in a country that only has 3 pathologists. And the MEPI has been instrumental in bringing back researchers who have trained in South Africa to set up and support a program in pathology and telepathology that links those activities in Malawi with people in the United States. In Makerere, cardiovascular disease, number one cause of death in the developing world, training people to do research in that area. And finally, the renewal of MEPI as we go forward, with Deborah Burks, our ambassador for PEPFAR, and Frances Collins, who's taken this on as a challenge, and where NIH has really expanded what we're doing on this platform. So the PEPFAR goals have been amazing, and we hope to see the aspiration of an AIDS-free generation only because of the breakthroughs and innovations that have occurred through research. And we cannot underscore the importance of research in an African environment by African scientists at African institutions as the key driver of this innovation. It's clearly important, but it's an aspiration that couldn't have been made a decade ago without the innovation. We have a long way to go to build up research communities in sub-Saharan Africa, but there's a lot that can be done. You know, we've changed the way we're doing global health research, from grants to U.S. institutions directly that subcontract to other institutions, to grants directly to the local institution and investigator. We've changed the training programs from training exclusively in the U.S. to sandwich programs between local institutions and U.S. institutions. We see the frontiers of science in the developing world essential for discovery, and we see these partnerships as absolutely essential because we cannot begin to do and make these differences ourselves. And I think part of my reason to come to Germany was to encourage and to see over the years investments by Germans and by the European community into these global efforts at these institutions. To end, what's the cost of not investing in global health research? Well, I think we've been plagued over the past several months by the Ebola outbreak. Began as a single focus that in the past 24 outbreaks has been totally contained by public health measures. But what's happened this time? Why the slow response, and what are the consequences? When we look at the mapping of global health research and where our investments have gone over the past year, and this is I'm going to end with this world report because I think it's an asset for all of you in the audience. We find a real void in the area of West Africa. And when we look at the area where the Ebola outbreak has occurred, it's really the area that's received the least attention and investment from the U.S. and global donors in both research support, capacity building, and innovation. These are difficult societies, and the research has not been there. If these outbreaks had occurred, as they did a couple weeks ago in Uganda, where there was an outbreak of Marburg, we hardly heard about that outbreak because it was so well handled by the Ugandans themselves. They had experience with a major Ebola outbreak in 2000, and they handled that without a fuss and without global spread. We feel that if the Ebola came into some of the MEPI countries that are well positioned through the training and research partnerships, the capacity building, that they will be able to address this much better than we're seeing in the countries affected today. So there's a lesson here about the importance and the value of long-term investments in training. I want to end with this slide of the World Report. We've gotten together with Alan, the Canadians, but with about a dozen of the world donors in research, and they're listed there, Canadians, the British, the Wellcome, the Gates, the Institut Pasteur, the EDCTP, CETA, and the like, to plot out our research investments in the world today. It's on the website, worldreport.gov. Do any of you use Yelp, so when you come to Berlin, you can find the best restaurant on your Apple iPad? Well, we see World Report as a Yelp for researchers, so that when you go to Kampala and you want to know who's doing research on cancer or on HIV or malaria, you can go to World Report and find all the researchers in country who are doing research that might have a synergy with what you're doing so that you can actually find and build partnerships. I think this is a tremendous asset to understand the value of partnerships and where investments can best be made. I want to just close with this slide because I think that what we've learned, again, is that investments in people and in institutions in low and middle income countries take scientific advance to where the problems are and lets us train the next generation of researchers to be retained in country, to see research as a viable option, and to participate in the innovation that's to come. So we see research and we see these investments as good for science. The new frontiers of science are not necessarily at home. It's good for diplomacy. It's smart power, if you will, in the regime of Hillary Clinton. It's clearly good for humanity to correct health disparities around the world. It's good for business and competition, and we heard from a business leader interested in this issue. It's good for our war on terrorism, and it's just good for our own future. It's the right thing to do, and I think part of that right thing to do are the investments in institutions, in people, and in the research agenda. Thanks so much for your attention.